Okay, so hello and welcome everybody. My name is Ratnu Vaidya. I am a fourth year medical student at Newcastle. I'm also the Northern Lead for the Faculty of Medical Leadership and Management. And in today's webinar, we're going to be going through one of the most interesting, engaging and exciting topics throughout the whole of medicine. I am talking, of course, about mental health law. So what exactly are we going to cover today? First and foremost, what we're going to do is we're going to think about why should we actually bother learning about mental health law in the first place? What relevance does it have for medical students? Secondly, we're going to be covering some of the key bits, which are the sections that are actually used in clinical practice and what we need to know about them as medical students. Thirdly, I'll be taking you through Dave's journey in our wonderful case scenario. And finally, I'll be touching upon how COVID-19 has changed the mental health law situation. But first, let's take a journey through history. If you see this image, you may be mistaken in thinking that it's my student flat at 2 on a Saturday morning. But the reality is much more interesting. This is an artist's depiction of what an old lunatic asylum would have looked like back in the 1800s. As you can see from the picture, it looks quite chaotic, quite disordered. There's not a lot of care going on and simply a lot of disorder happening. So what were asylums of the past like? Firstly, they were very, very squalid and very, very dirty. They're not exactly places that you wanted to be in. Secondly, and quite importantly, asylums were completely unregulated. There was no law, there was no regulation, there was no means of good practice to ensure that people received good quality care. And thirdly, there was a very poor regard for people's mental health. Mental health as a topic, mental health as a simple entity did not really exist back in those days. So for our first SBA, I'd like you to think, what was the name of the first ever mental health law introduced in the UK? And your Kahoot should have loaded up now. Okay, well done to the 7 of you that got the Madhouses Act. So the Madhouses Act of 1774 was the first proper mental health law that was introduced in the UK. And what this aimed to do was to prevent any unregulated admission to lunatic asylums. Before then, you'd often have quite frustrated or quite annoyed husbands who would simply ship their wives off to lunatic asylums with the hope that they'd be free from them. As you can understand, this ethically wasn't that great. And all these quite unscrupulous asylum owners would simply let anyone in without any rule, without any rhyme, without any reason, simply if they could pay. What this act also introduced was increased input from physicians. Previously, mental health asylums didn't really have any doctor's input. And so this act seeks to change that. So why is it important for medical students to learn about mental health law? First and foremost, it's a highly examinable topic. Mental health law is something which comes up quite regularly in the SJT, and it's one of the sort of concrete elements of psychiatry which comes up in SBAs and throughout the examination process. So it's going to come up a lot in exams. Secondly, it's not something that's just resigned to textbooks. Mental health law is something which you will see day in and day out in clinical practice. And it's not just resigned to psychiatry either. It's important to know what laws and what structures are in place for vulnerable patients across the country, which ties into my next point. But what mental health law is it simply just a framework to help some of the most vulnerable people in our society. Often these are people who may come from low socioeconomic backgrounds, from immigrant background, all these things which put people at increased risk of mental health problems. And so as doctors of the future, it's our moral duty and obligation to ensure that we keep up to date with what law is and how we can best apply it to suit the patients that we're here to treat. So the next thing that we're going to do is we're going to look at some of the current legislation that's happening in mental health law. And this is the Mental Health Act. This was created in 1983 and amended in 2007. So what exactly is the Mental Health Act? The Mental Health Act is something which applies in England and Wales, a series of laws, and it applies to people with a mental disorder. As a society, we look we don't agree with restricting people's liberty unless it's absolutely essential, say if they've done a crime or if they're at risk to themselves or others. But the Mental Health Act sets out that framework when someone's liberty needs to be restricted under the grounds of mental health. But what actually constitutes a mental disorder? A mental disorder means many different things to many different people, but in the Mental Health Act, they sought to codify it into several key topics. The first of which is psychiatric illness. So this can be something like schizophrenia, depression, bipolar affective disorder. It can also be something like a learning disability, but that's only if it's associated with challenging or aggressive behavior. Another element of what constitutes a mental disorder is intoxication and withdrawal. But in contrast, dependence isn't actually classed as a mental disorder. So there's an interesting disparity there. So what exactly is a section of the Mental Health Act? Quite simply, a section is where you keep somebody in hospital under this act. It's restricting their liberty and putting them in a place of safety to ensure that they're not a risk to themselves or a risk to other people. And now we're going to be going through some of the key sections involved in clinical practice. The first of which is Section 2 of the Mental Health Act. Section 2 is where you admit somebody for diagnosis and assessment. This can be because the person has a first presentation of a mental illness and immediately needs some sort of care to put them in a place of safety. If a diagnosis isn't known and they need to be assessed, a Section 2 will often be used. A Section 2 lasts for up to 28 days. In this time period, it's expected that an assessment is done and a diagnosis is formulated. An important thing to know about a Section 2 is that it cannot be renewed. Once those 28 days are done, they are done. But how do you actually apply that in clinical practice? Let's go to a clinical example. Let's say you have a patient who's presenting with low mood and anhedonia, which means a loss of pleasure, with delusions of worthlessness. Straight away, you may be thinking something along the lines of this person may have depression. But what's concerning about this is the high suicidal ideation. This means that the person may be at an increased risk to themselves in terms of dying by suicide or perhaps ending their own life. So as a result, a person like this, who has a new presentation, would be taken into a mental health hospital for assessment under Section 2 of the Mental Health Act. So to recap, Section 2 is for diagnosis and assessment, and it lasts for up to 28 days. Moving on now to Section 3. One of the easiest and key ways that I remembered Section 3 is for treatment is thinking of Mike Tyson and his lisp. So just think, whenever you think Section 3, think treatment. So just to reiterate, a Section 3 is when you admit somebody for treatment. They'll often have a pre-existing diagnosis and tend to be known to services. In contrast to a Section 2, a Section 3 has a 6-month duration. This means that it doesn't last for only 28 days, it lasts for about 6 times that, so it's far, far longer. Another thing to recognise about a Section 3 is that unlike a Section 2, a Section 3 can be renewed. It can be renewed for 6 months firstly, then another 6 months, and then for 12 months at a time. So I like to remember this as 6, 6, 12. If someone's on a Section 3, they're renewed for 6 months, renewed for another 6 months, and then renewed for 12 months at a time. And this can be done indefinitely for the rest of their lives if it so happens. But how can we apply this in clinical practice as well? If we think about a patient with a known condition, say for example, established bipolar disorder, who's already known to services, if they're having a manic phase, then there's no need to go through a Section 2. Because the patient's already known to services, because their diagnosis is already established, they can be taken to a mental health hospital under Section 3 immediately for treatment. But what are the professionals involved in the sectioning process? And for the next one, we'll be moving on to another SBA. Okay, well done everyone, and well done to the 3 people in particular that put Ghostbusters. So yes, you're absolutely right. The professionals involved in the sectioning process are 3. There's an AMP, which is also known as an approved mental health practitioner, and 2 doctors, one of whom must be Section 12 approved. So going through that in a little bit more detail, you have an AMP, who can be a social worker, an occupational therapist, or a registered mental health nurse. Previously, this used to be just social workers, but following the Mental Health Act of 2007, this was amended to also include occupational therapists, mental health nurses, and other allied professions. There are also 2 doctors involved in the sectioning process, one of whom has to be Section 12(2) approved. Now, this is most commonly a psychiatrist, but can also be a GP with interests in mental health. And another doctor should be involved who also knows the patient, which commonly is the patient's GP. So in practice, you sort of have this dynamic trio. You'll have a social worker, a GP, and a psychiatrist who's Section 12(2) approved. I like to think of these 3 as SpongeBob, Patrick, and Squidward. You can take from that what you will and assign whichever characters you want to whichever role. Moving on to some other sections of the Mental Health Act now. What exactly are holding powers? So holding powers are unique compared to Section 2 and Section 3, and that they're for patients who are admitted informally. So these are patients who have come in for voluntary treatment without coming in under a Section 2 or a Section 3. But if that patient tries to leave, and if that patient may still be at risk to themselves or others, then there need to be certain checks and safeguards in place to ensure that the safety of the patient and those around them are maintained. There are 2 main holding powers that clinicians should know about. One of which is the Section 5(2). So this is the doctor's holding power, which only applies to fully registered doctors. So if you're an F2 or upwards. It lasts for up to 72 hours, in which time it allows a person's assessment to be arranged. In contrast, a Section 5(4) is the nurse's holding power. This only lasts for 6 hours and is often viewed as a last resort. Only if you can't find a single doctor throughout the whole hospital would you carry out a Section 5(4). And what this tends to do is it tends to allow doctors within that 6 hours to carry out the 5(2). Moving on now to something completely different. Magistrates and police officers' orders. These aren't normally conducted by clinicians. So let's take a look at what they are. A Section 135 is also known as a magistrate's order, which is applied for by an AMP. In situations where a person is at risk to themselves or others, staying inside their own home, it grants the police powers to enter that person's home, and it lasts for up to 72 hours. When we apply this clinically, we might have a situation that looks a little bit like this. If we think about 80-year-old Doris, who stopped taking her dementia medication, becomes acutely confused, doesn't really know what's going on. If she's not allowing medical professionals into her home for treatment, then there's a good chance an AMP may need to apply for a Section 135 for a warrant to come in with the police. When successfully applied for, this Section 135 is used by the police to gain entry and take that vulnerable person to a place of safety from their home. So just to recap, Section 135 is a magistrate's order. It's applied for by an AMP, and it applies in situations where somebody is in their own home and may be at risk to themselves or others. In contrast, a Section 136 is a police officer's order. This is an intrinsic power that police officers have, and quite similar to a 135, is used in situations where people are at risk to themselves or others. But as opposed to being inside someone's home, this section is applied outside of the home, and it allows the police to take somebody from a public place to a place of safety. This place of safety can be somewhere like their home, a police station, or a mental health hospital. One of the ways in which this is applied clinically is when someone, for example, is attempting to jump from a bridge. The police officer doesn't need to apply for a warrant, go through the whole magistrate's process in that period of time. They simply utilize the powers that they have of a Section 136 and take that person off from the bridge and to a place of safety, which can be, just to recap, a mental health hospital, their home, or a police station. So thinking about another SBA, what's the most appropriate section for a patient whose Section 5(4) has expired? Well done to all of you that selected Section 5(2). That is absolutely the correct answer. So the reason why it's the correct answer, because as we know, a Section 5(4) is a nurse's holding power, which lasts for 6 hours, which normally tends to be used to allow the doctor to arrive and carry out the Section 5(2). Okay, so we've learned a little bit about all the different sections involved. Let's go through a journey. let's go through Dave's journey. So who is Dave? Dave is a 62-year-old man living alone in Newcastle in the northeast of England and is a former shipbuilder. Dave has normally quite an active social life. He loves footy, supports Newcastle United, despite somehow managing to wear a Man City hoodie and being in the Man City grounds, and also loves Greggs. He likes to spend his time at the pub, talking to friends and meeting family. But recently, things have started to change. Things have started to be not quite right. We think about Dave's history. He recently lost his third job in a year. He stopped meeting his family as often, and understandably, people are starting to get concerned. And when he does meet people and does meet his friends and family, he begins to appear snappy and withdrawn, not the normal, friendly, happy Dave that we've all seen before. So at this point in time, I want you to imagine that you're the GP. Dave's nephew has come in to tell you that something doesn't seem quite right. Dave's been snappy, he's not been returning phone calls. What's your first action that you do? Okay, well done, everybody who selected arrange a phone call with Dave to check how he's doing. Thankfully, none of you selected to call his friends and ask what they think, because as we all know, this would be a breach of confidentiality and you shouldn't be talking about somebody else's health. So absolutely, the correct thing to do is to arrange a phone call with Dave, see how he's doing. So you do exactly that. You pick up the phone and call him. But things don't seem quite right there either. On the phone, Dave seems very hostile, very suspicious. He's convinced that you, the medical professional, are one of them. He doesn't exactly specify who one of them actually are, but you're starting to get quite a worrying tone from what he's saying. From your fantastic undergraduate teaching in medical school, you recognize some of the key features and some of the key symptoms of a mental disorder. You notice that he's got pressure of speech, where he's talking really, really quickly, and it's as though he's trying to force the words to come out. And he's also having delusions of persecution, where he's feeling he's being unfairly targeted. In this situation, he's mentioning cameras. So as a GP, you'd be understandably quite concerned and quite worried. So you feel as though he's sufficiently high risk to warrant going out to see him. So off you trot, going along, trying to have a chat with Dave, but there's no answer at the door. And what's even more concerning is that the windows appear to be barricaded. So there's clearly something that's very not right going on here. And this should start to ring a few alarm bells. Could this person be at risk to themselves? And could this person be at risk to other people? So if we think about what we've learned, Dave's inside his home and is not refusing any engagement and is refusing any engagement with mental health services and the GP. Which section is most appropriate in this scenario? Okay, well done to everybody that selected section 135. This is the correct answer because section 135 is a magistrate's order which is applied for by an AMP, which when somebody's inside their own home and could be at risk to themselves or others, allows the police to gain entry. So yep, section 135 is absolutely the correct answer. So moving on, the magistrate approves of section 135, the police break in, sees lots of recording paraphernalia, all the sort of stuff which would indicate that there's something quite wrong going on. Dave's taken to his local mental health hospital where an assessment is carried out. There's a working diagnosis of suspecting acute and transient psychotic disorder. For those that are particularly keen, this is the ICD-10 code F23. So moving on now. What precipitating factor amongst Dave's risk factors is likely to have caused this? Yes, absolutely right. The precipitating factor that's likely to have caused this is a recent job loss and not a receding hairline. So if we go through what predisposing, precipitating and perpetuating factors are a little bit more to get some clinical context. A predisposing factor is a factor that increases someone's risk of developing a mental health problem in the first place. In Dave's case, this can be something like a family history of schizophrenia. It can be something like having no social support network in terms of living alone, and also being male has an increased risk. In contrast, a precipitating factor is a specific event or a trigger that can cause somebody to experience a mental health problem. In this case, it's most likely to be Dave's job loss. In other cases, in patients that you can come across, it may be things like unemployment, as we said, like divorce, having a baby, moving house, any sort of major life stressor that's likely to have a big emotional impact on someone. And perpetuating factors are the factors which allow the mental health problem to continue. This can be some of the similar ones to the predisposing factors. Say, for example, if Dave doesn't have a good support network and doesn't have that to rely on, this mental health problem is going to carry on. There's also things to consider like compliance with treatment, whether Dave is engaging with health services. If Dave doesn't engage with health services, then obviously there's a higher chance that these problems are still going to carry on and continue. But at this point, he's under a Section 2 and is becoming increasingly restless and is trying to abscond from the ward. This is something that's quite concerning. So you, as a junior doctor, what would you consider in this scenario? Oh, so quite a broad mix there. So in this scenario, he's already on a Section 2. This means that he's not under an informal section. He's been formally sectioned and formally placed in hospital, which means that he doesn't have a right to leave. And so in this case, no section would be applied. Section 5.2 and Section 5.4 only apply when someone is on an informal section who is not on a section and informally come into hospital. So in this scenario, the correct answer would be no section needed. So moving on now, within the 28 days, Dave is diagnosed with paranoid schizophrenia. He's had a full-blown diagnosis and is kept under Section 3. Thinking back to Section 3 and what we discussed earlier, how long does it last before renewal? Yes, absolutely right. A Section 3 lasts 6 months before renewal. Just to recap, Section 3 is for treatment. It lasts for up to 6 months, can be renewed for another 6 months, and another 6 months, and then 12 months at a time. So just remember, 6, 6, 12. Okay? So as we said, 6 months is the time before renewal. And coming towards the end of Dave's journey now, his condition improves after he's prescribed olanzapine, which is an antipsychotic. And thanks to all of your hard work and being excellent members of the medical team, he's no longer experiencing psychotic symptoms. He remains stable for the next few years on medication, and he's eternally grateful for all of the work that the medical practitioners have done, and especially grateful for their extremely good knowledge of mental health law. So let's move on now to what actually happens during COVID-19 around mental health law and what changes have been made. Normally, when you're sectioning somebody, you need 2 doctors, one of whom is Section 12.2 approved, one of whom already knows the patient, and you also need an AMP. But due to increased clinical commitments and due to other factors around mental health law during COVID-19, only 1 doctor is now needed for sectioning. Secondly, there have been changes during the appeals process. If you're admitted under Section 2 or Section 3 and want to appeal your decision, you go to a mental health tribunal. This tribunal normally consists of 3 members, one of whom is a judge, one of whom is a layperson, and one of whom is a psychiatrist that's not involved in your care. Since COVID-19, this has changed, and that only 1 legally qualified person is needed at a mental health tribunal. So what have we learned today? Firstly, we've gone through a bit of the history around the Mental Health Act. We've gone through the Madhouses Act of 1774 and how things were compared to how things are now. We've learned that the Mental Health Act sets out the rights of people who have mental disorders. This includes things like psychiatric illnesses, acute intoxication, and learning disability, but doesn't include dependence. We've learned that Section 2 lasts for 28 days and is done for diagnosis and assessment. We've learned that Section 3 is for treatment. It lasts for 6 months, it can be renewed for 6 months, another 6 months, and then for 12 months at a time. We've also learned what holding powers are, which are applied when somebody is admitted informally, so not on a section. This is 5.2, which are the doctor's holding powers, and 5.4, which is the nurse's holding powers. A doctor's holding power lasts for 72 hours, and a nurse's holding power lasts for 6 hours. We've also gone through a little bit about the different orders, the magistrate's order and the police officer's order. The magistrate's order is Section 135, which is a warrant issued for somebody to go inside the house of somebody else who may be experiencing a mental health problem and needs to be taken to a place of safety. Alternatively, a section 136 is the police officer's order, which is a power intrinsic to police officers. And what happens is if somebody is suspected to have a mental health problem in a public place, they are taken to a place of safety. This can be somewhere like their home, a mental health hospital, or a prison. But the single most important lesson of all that I want you to take from this webinar is that the care and the safety of the individual always comes first. It's not the be all and end all if you didn't memorize every single last one of these laws and every single last way that they're applied. But always think about the patient in front of you, how they are, how they're being treated, and how you can make their lives better. Because as medical students and junior doctors, it's what we signed up for. So thank you ever so much for your time. I just have one final question to ask of you. Okay, thanks a lot. And once again, it's been lovely to speak to you and have a chat about what mental health law is and how it's applied. If you have any further questions, feel free to email me. My email is up there. And you can also get in touch with me via Twitter. My Twitter is @Ratnu_Vaidya. Once again, a massive thanks to the Medics Academy team for hosting the virtual elective series. It's been an absolutely brilliant opportunity. I strongly recommend to everyone to apply to learn more about it, particularly in these COVID-19 times where there's not as much to do. Once again, thank you ever so much for your time. If there are any questions on Slack, then I'm happy to take them now.
Okay, thank you very much, Ratnu. My video will start. Hey, so thank you very much for to Ratnu for that wonderful look through at what can be a very dry subject, but as I'm sure you'll all agree, his radio DJ-esque voice really brought it home for me, which I really enjoyed. So thank you for Ratnu for that. So we don't have any questions for Ratnu from the Slack, which is of course because he was so comprehensive and clear in his lecture, which is wonderful. So again, thank you to Medics Academy for hosting this, and the applications for the virtual elective I think are still open, certainly for July, if not June. So be sure to have a look at that, and there'll be quite a few webinars over the next 4 weeks from the rest of the team that have been working hard on virtual electives. So many thanks to Ratnu, and thank you to all of you for coming. If you've got any quick questions that you'd like to ask Ratnu, if you put them into the Slack, then I'm sure that'll come across and we can have a quick answer of those. And if not, enjoy the rest of your week. Thank you very much.
Thank you.